There has been some confusion regarding periodontal treatment planning and diagnosis. So I'm going to go over really quickly a study sheet that I made for us to study and to discuss for a quick 15-minute breakout session next Wednesday. Okay, so I'm going to start off by talking about our periodontal charting standards. So it's important for us to probe 6-point probe per tooth, which we already do. We also it's important to do bleeding points per pocket. Something that we don't do consistently is recession, and this is not just where charting where the recession is, but you have to chart every single tooth because if there's no recession, you have to chart a 0. And I'll tell you why that's important in just a bit. When we're diagnosing periodontal disease, it's not just based on pocket depths. We are diagnosing off of clinical attachment loss. So, what is clinical attachment loss? It is the distance from the cemental enamel junction, or the bottom of the crown where the root starts, to the bottom of the pocket. So that the clinical attachment loss needs to be 5 millimeters or greater in order to qualify for SRP, not just a regular pocket depth. So you can have pseudo pockets where, and more common in adolescents or patients that don't have bone loss but have puffy gums. That's where the gums are actually on the clinical crown. So that's a kind of a fake pocket. That patient has no bone loss and will not qualify for SRP. So this is our, periodontal chart. So you can see here the gingival margin, if there is no recession, you have to put 0. If the gingival margin is on the clinical crown and it's puffy, you have to select and check this gingival margin plus and then put in the number, and that's like hyperplastic gums. So when you enter in all these gingival margins, the clinical attachment loss will auto calculate. And these are the numbers that we need to look for when seeing if the patient actually qualifies for SRP. So insurances are going to look at this row, the auto clinical attachment loss, to see whether or not they qualify. The next thing I'm going to be talking about is our periodontal treatment planning standards. So there are 3 types of procedures that we can do for our patients under the periodontal treatment planning. So there's prophy, gingivitis scaling, and SRP, right? So your typical patient that comes very regularly, right? Minimal bleeding, maybe some light calculus, light plaque, no, clinical attachment loss, no radiographic bone loss. Those are our typical prophy patients. They're very regular, very little bleeding. Now, the patient maybe who hasn't been in for a couple years, maybe a new patient, maybe a patient in ortho, where their gums are puffy, and when you touch them, there's generalized bleeding. But when you look at the x-rays, you don't see the 2 millimeters of clinical attachment loss, which we need. So they might have a lot of pseudopocketing. So this is tricky because you might have a lot of 5 millimeter pockets, but it doesn't mean that they qualify for SRP, because if there's no radiographic bone loss, then they won't qualify. And then, of course, you have the SRP, which is irreversible. These are patients that have bone loss and they are in danger of losing teeth if the periodontal disease does not get better, right? So what are you going to ask yourselves? Step 1, is there bone loss, right? So on Pearl AI, the nice thing about having that is it's going to measure this for us. So we need interproximal bone loss of 2 millimeters or more. So look at those numbers from Pearl and look and count how many teeth you have. If it's no, right, it's going to be either a gingivitis scaling or prophy. So is there a lot of bleeding? Are the gums really puffy? If it is yes, then it's gingivitis scaling, right? So what's your typical gingivitis scaling patient going to look like? Um, maybe they haven't been into the dentist for 1 to 5 years. Gums are red, swollen, bleed easily. They may have some 5 millimeter pocketing, but minimal or no bone loss on the radiographs. This can be someone with poor home health, right? Plaque heavy patient who doesn't brush consistently, lots of inflammation everywhere, um, no attachment loss, right? The young adult with inflamed gums that maybe 20s to 30s, puffy tissue, doesn't like to brush, bleeding everywhere, gingivitis scaling, or your, um, you know, pregnant patient, right? Hormones are going crazy, gums are really swollen and inflamed, or patients on um, certain medications like calcium channel blockers, super common for hypertension. That can cause hyperplastic gingival tissues. So be aware of that. Or patients in ortho, right? So this is a picture of a patient. If you look at their radiographs, you won't see bone loss. I know you're going to want to do SRP, but they will not qualify because there is no bone loss or clinical attachment loss. Okay. Mistakes when diagnosing SRP, right? Oh, we have some 5 millimeter pockets. Let's diagnose SRP. No, it's not based on the pocket depths. It's based on the clinical attachment loss. That's why it's so important for us to chart the recession even there when there is none, or if it's a positive, meaning it's on the clinical crown, the gingival margin. Mistake number two, ignoring radiographs, right? So you don't have the 2 millimeters of bone loss on Pearl AI. You don't have any calculus. You don't have those boxes on Pearl AI. Your bite wing does not show the bone levels on both the upper and lower jaws, or the bite wing is more than a year old at time of SRP. Mistake number three, incomplete periodontal chart. So bleeding points not documented. You don't have the 6-point probing depths, or you don't have the 6-point gingival margins documented. We need this to calculate the clinical attachment loss. Other reasons, maybe you didn't have enough teeth that qualified for the full quadrants 4341. It needs to be 4 or more teeth with clinical attachment loss, not pocket depth, clinical attachment loss of 5 millimeters. For 342, 1 to 3 teeth per quadrant. Okay, wisdom teeth don't count. They don't count the wisdom teeth. And they also sometimes don't count second molars where the bone loss was due to an impacted wisdom tooth. So be careful there. SRPs are only covered every 24 months. So if they've had SRPs within 2 years, it's not going to be covered. You have to be careful. If you do more than 2 quadrants per day, they will not cover it, unless the patient is doing like deep sedation and it has to be documented, a good reason why more than 2 quadrants are done. Or if a prophy, gingivitis scaling, or periodontal maintenance was performed the same day as SRP. Okay, so I'm going to record some examples of x-rays of things that we just saw in the office, right? So this first x-ray that I'm showing you, there's calculus on the tooth, and there's bone loss. Look at this, 6.1, 5.8, so it definitely qualifies. But look, you can't see the bone level, right, on bottom or top. So we should have taken a vertical bite wing in this. Uh, it's great that we see bone loss, but it doesn't help us that we can't see the bone level. In the second patient, it was diagnosed for full SRP, upper left, lower left. But look at these measurements, 1.2, 1.2, 1.5, 1.3. I don't see any twos. I don't see any radiographic calculus. So this claim will definitely be denied for this full SRPs. This third patient here, um, diagnosed for full quadrants of SRPs, upper left, lower left, but I only see maybe 2 teeth with this 2 millimeter number. All the rest are under 2, so maybe partial SRPs were warranted and indicated, but definitely not full. So the insurance will probably downgrade this to a partial SRP. In this third x-ray here, um, you can see that there is calculus. It looks like it's pretty high up, so it's probably supragingival calculus. But look at these measurements, bone loss measurements, right? 0.9, 1.5, 1.2, 0.8, 0.7. This patient in our office was diagnosed with for full SRP upper left, lower left, and it's going to be denied. They probably won't even downgrade it to a partial quadrants. In this x-ray here, this is a good example. So it looks like we took a vertical bite wing. So that's really good. We can see the bone level on top and on bottom, and there are multiple teeth with clinical attachment loss, CEJ, to bottom to the bone, where it's greater than 2 millimeters. So this one definitely probably would qualify. And thank goodness we took this vertical bite wing. So just remember, it's not just about 5 millimeter or greater pocket depths, it's the clinical attachment loss. And you need to see that on Pearl AI with these measurements, and you need to see these boxes with calculus. If you don't see that, then the patient does not qualify for SRP. Let's do gingivitis scaling instead.